Traumatic cataract in a young girl. Management of an ocular trauma is challenging, especially in children. The challenges include examining the child, handling the anxious parents, and risk of amblyopia in the future. Compared with adults, children's eyes will have more inflammation, high risk of synechial formation, and posterior capsule opacification. We are going to share management of a traumatic cataract in a girl who had a full-thickness corneal laceration wound and had underwent emergency corneal toilet and suturing. After the conjunctival peritomy, braided suture was done. As the patient was under GA, we need to pull the eye downwards to have wider surgical view. IOL calculation was taken from the other uninjured eye, as the keratometry of the injured eye will not be accurate. Target refraction for kids depend on the age. The younger they are, the target is more hyperope as the kids will grow and there will be myopic shift. In traumatic cataracts, there are risks of weak zonules and posterior capsule. Make sure to have a 3-piece IOL and a capsular tension ring standby. Superior incision is preferred, which allows wound to be protected by the eyelids and by the Bell's phenomenon, especially in trauma-prone childhood years. Scleral wound was created to reduce risk of corneal astigmatism in the traumatic eye. Crescent blade helps to create a smooth scleral tunnel. Paracentesis of the side pod was done using a 15-degree blade. Usage of the trypan blue aids in capsulorhexis creation by enhancing visualization and by providing capsular stiffening. The ophthalmic viscosurgical device was injected to form the anterior chamber before the main scleral wound was created. The main scleral wound was created using a 2.75mm slit knife. The anterior capsule in children is extremely elastic, which can make the creation of the capsulorhexis more difficult. A cystotome 26-gauge needle was used to help create the initial flap for the capsulorhexis. As the capsule in kids are more elastic, we have to be more careful and make sure the tearing force always directed to the center of the pupil to make a curvilinear tear. Next precaution in traumatic cataract is to do hydrodelineation rather than hydrodissection, as there is possibility of a weak posterior capsule. The lens in pediatric cataract is generally soft. Gentle lens aspiration is performed using automated lensectomy technique. Posterior capsulotomy can be performed in children less than 6 years of age to prevent post-operative visual axis opacification. It can also be performed in children older than 6 years with developmental delay or with nystagmus who may not be cooperative for laser capsulotomy at a slit lamp later. Techniques to perform posterior capsulotomy are similar to anterior capsulotomy. In this patient, it was not done as the patient's age is 9 years old. After gentle lens aspiration, now we are injecting the ophthalmic viscosurgical device to prepare for intraocular lens insertion into the bag. IOL implantation is the primary mode of visual rehabilitation in children more than 1 year of age. Preferred IOL material is acrylic hydrophobic foldable IOLs. It has unique benefits in children due to increased biocompatibility. There is also less risk of post-operative inflammation and posterior capsule opacification. After stabilizing the intraocular lens, the viscoelastie was removed. There was iris prolapse of the wound, so air bubble was inserted to aid with the suturing. The scleral wound was sutured using nylon 10-0 suture. In pediatric patients, all wounds must be sutured. This is because compared to adults, they are more active and more prone to injury. In conclusion, the management of traumatic cataract in pediatric patients should be varied according to the age, the mode of injury, the traumatic type, and associated injuries. Timely intervention in pediatric patients is important to prevent amblyopia. Okay, that's all for now. Hopefully everybody will get some benefit from this video. Thank you very much.